Hello, everyone. I want to dedicate this talk to my mentor and friend, Sam Gambhir, who recently passed away. Today, I'm going to talk about our approach to non-invasive molecular imaging and the impact that it has on the localized disease and suspected recurrence in prostate cancer. We're going to spend the next 10 or so minutes discussing a few topics. The first one, what do we target in prostate cancer and why? There are many targets for diagnosis and treatment in cancer biology. Of course, it's very complex. In prostate cancer at my institution, we in nuclear medicine are looking at two targets. Of course, prostate-specific membrane antigen, it's a topic that has expanded tremendously over the past decade, and there's not a single talk of prostate cancer that does not include PSMA. However, as good as PSMA is overexpressed in more than 90% of prostate cancer, I think that we need other targets as well to complement PSMA. And one such target is a group of receptors called gastrin-releasing peptide receptors. These are overexpressed in a variety of major cancers, including prostate, but also estrogen receptor positive breast cancer, small cell lung cancer, and other malignancies. Again, I think that the combination of the two is better than each one individually. These are normal biodistributions of PSMA on the left and GRPR on the right as imaged with PET. At my institution, we use both gallium PSMA-11 and F18 DCF-PYL. So for PSMA imaging, although called prostate-specific, obviously this is not the case, as we have uptake in salivary and lacrimal glands, as well as clearance to the hepatobiliary tract into the bowel, uptake in the spleen, and significant clearance to the kidneys into the bladder. Differently with a GRPR, in this case with a small peptide called RM2 labeled with gallium-68, above the diaphragm there's no significant uptake, there's minimal hepatobiliary clearance. The pancreas has the highest normal uptake, and then the tracer is eliminated through the kidneys into the bladder. So there are advantages to each of these for different indications. I think, as I said earlier, the combination is probably better than the parts, with the acknowledgement that PSMA is now widely used worldwide in prostate cancer. So next topic I'm going to discuss is how we use these tracers for biopsy guidance in men with suspected prostate cancer. This is not a small category where PSA is rising or PSA density is high, yet the MR is equivocal or negative. So our project is using both PSMA and RM2 in men with high prostate density, but equivocal or negative biopsies. So undiagnosed prostate cancer, but highly suspected. In this example, we have faint uptake on PSMA. We have focal uptake with RM2, and this shows the needles that missed in green the cancer and then the cancer present after guidance from PET imaging. And this is one of the systems that can be used for biopsy guidance. This is another example where both PSMA and RM2 show the same cancer in the peripheral zone of the right lobe of the prostate. Another area, again, of precision detection, but also precision treatment is to use PET for guidance of local therapies. In this case, high intensity frequency ultrasound or high dose rate brachytherapy. Again, a few examples. This is PSMA demonstrating uptake in the peripheral zone, the left lobe of the prostate, similarly with RM2. There's also another cancer on the right. This is a clearance in the urethra. So if you only knew about one cancer and you apply focal therapy, you may have missed the other one. A couple other examples. Here, the PSMA is positive in the peripheral zone of the right lobe of the prostate, and RM2 shows no uptake there. So if you used RM2, you would have missed the cancer. Here you have one lesion on PSMA, several other with RM2. And again, if you only use one tracer, you would have missed some of the other lesions, which is particularly important for HIFU, where you treat a specific area of the prostate, not the entire gland. Perhaps less important for high-dose rate brachytherapy, where the entire gland gets some degree of radiation, but you can boost the area that you see on PET imaging. This is one of the first examples where we have imaging before and after HIFU, 6 months later. These in green are needle tracks that were benign findings, and in red, clinically significant prostate cancer, so Gleason score 7 or higher. The top row are the images prior to HIFU here with RM2, we appreciate uptake in the right lobe of the prostate, that's urethra clearance, and on PSMA also uptake in the right lobe of the prostate. This lesion was treated with high-intensity frequency ultrasound and the signal disappeared 6 months later, both on RM2 as well as on PSMA imaging. So perhaps with this technique going forward, we will be able to avoid rebiopsying lesions at the end of treatment. And we know that post-treatment MR has difficulties identifying active disease versus changes related to the treatment itself. This is an early example from the work done prior to and after high-dose rate brachytherapy. This is a lesion that was biopsy proven to be recurrent prostate cancer in the gland, and this was treated with high-dose rate brachytherapy, and the signal disappeared. And again, hopefully we will be able to avoid rebiopsying this man if the signal absent on PET correlates with outcome as we follow up these patients with PSA measurements. Another area where we can use this dual radiopharmaceutical PET approach is to identify the extent of disease in patients scheduled for prostatectomy and pelvic lymph node dissection. This is a summary of the data to date, the patients who received both RM2 and PSMA-11, and in red highlighted findings that were different between the two. The images on the right are from the same patient at various levels in the pelvis. So top row prostate, there's one cancer identified with PSMA-11, not seen with RM2 in the same patient, and other cancerous lesion seen on RM2, not with PSMA-11. And the bottom two rows are identifying lymph nodes, pelvic lymph nodes, that are seen in this case with both. And in the bottom row, perhaps a little bit more conspicuous with RM2 than with PSMA-11. A few more examples from this clinical scenario. Here's the primary cancer located in the posterior right lobe of the prostate gland, seen with both RM2 and PSMA-11. In the same patient, the perirectal lymph node is perhaps more conspicuous with RM2 than with PSMA-11. And another lymph node in the same patient in the presacral space, it's definitely better seen with RM2 than with PSMA-11. Of course, in this scenario, you can have micrometastatic disease that will not be identified by imaging. So this imaging method is specific, but the sensitivity may lack for very small lesions. Our group is evaluating outcomes data in these patients, and we want to see if lymph nodes are present on imaging prior to surgery. If these patients have a worse outcome than those without lymph nodes identified on imaging, intuitively that should be the case. And another example here where with RM2, we identify one cancer, with PSMA, we identify another in the same patient. So it's not always the case that the two find different lesions, but there are enough examples like this that make us think that the combination of the two radiopharmaceuticals is the way forward, at least in some of these patients. What do you do about biochemical recurrence? Biochemical recurrence occurs in majority of men with prostate cancer after initial treatment, and you need to be able to accurately and early identify the site of recurrent disease. These are some examples from our group where, in this case, a few lesions seen with RM2, but much more seen with PSMA-11. The opposite of that in this other patient, where more lymph nodes are seen with RM2 than with PSMA-11. And here, similar bone lesions with both radiopharmaceuticals, and the last example, more bone lesions seen with PSMA than with RM2. These are the positivity rates in this clinical scenario. For RM2, they're slightly lower than with PSMA. But what we've also noted is that the PSA velocity, which is a marker of tumor aggressiveness, is higher in patients with positive RM2 than those with negative RM2, and this difference is statistically significant. So perhaps, yes, we will miss some cancers, but those that we miss may be the ones that are more indolent. We have to see if in larger groups of study participants, these results will hold. This is important because there is now technology, in this case, a reflection biology-guided radiation therapy that takes into account the PET signal to guide the external radiation beam. So if you have an example with several lesions compatible with biochemically recurrent prostate cancer, perhaps you can use PET-guided radiation therapy, very new technique, precision treatment of these men with prostate cancer. And then why not combine it with theranostics? And this is the last topic I'm going to touch in my presentation. The audience is probably familiar with this concept. If you identify a target, you can use and think of it as a lock. You can use a peptide as the key to unlock And then if you have a good chelator, a linker, you can attach to it a radionuclide that can be used for both diagnosis. And if you see the disease, then you can attach another one for therapy. So adapted from the same paper by Michael Hoffman at Peter Mac, you can have the example of PSMA theranostics where the target is PSMA. And this is one of the several diagnostic tools. And then if you see disease, you treat it by attaching most commonly lutetium-177 and also other emitters as well. You can do the same with gastrin-releasing peptide receptors. In this case, the target is the GRPR. And you can have a couple of these peptides labeled with gallium-68 or lutetium-177. There are many trials of PSMA. Some large phase 3 trials have concluded and we're waiting for the results. There are also starting to be therapy trials of GRPR. This is from Novartis with their peptide, NEOB. There's a phase 1, phase 2 study that's described here. There's preclinical data with lutetium-177 RM2 that is shown to be effective in preclinical studies and also is shown to work better if combined with a radiosensitizer such as rapamycin. The concern for toxicity in the pancreas or kidney is real. However, data that has been collected so far indicates no evidence of treatment-related toxicity. These are images from the first patient treated with lutetium RM2. And interestingly, while we see the pancreas on the early images, the signal washes out from the pancreas on the delayed images while being retained in metastatic lesions, which is very encouraging because we want to minimize the dose to the normal organ pancreas and maximize it to metastatic lesions. Recently, the group in Rostock in Germany did the first human dosimetry study, and they've shown what was expected, that the biokinetic and dosimetric results are very similar to other lutetium-177 labeled peptides. And therefore, we're seeing that lutetium-177 RM2 will play a role in a selected group of patients with prostate cancer. Our group is investing in this as well. This is our clinic, and in this space that was a physics lab, we are now building a theranostics clinic that will have individual space for patients where we hope to translate as many of these treatments as possible. This is work that has been done with the help of many colleagues, and here are some of them working on PET, MR, theranostics in prostate cancer. With that, I would like to thank you for the invitation to present. I'm honored to be in great company, and I'm honored to participate in the symposium. Thank you.